All right, thank you everyone for joining us for this month's Science Cafe on health informatics. So, I just want to provide a brief overview of the CTSC for those of you that are not familiar. Our goal is to improve the health of those that live in Northern Ohio and beyond by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists, as well as community members. The CTSC is currently doing this by focusing on these five key areas and initiatives. So, resources and services, workforce development, community engagement, health informatics, and clinical and translational funding opportunities. And I want to introduce our presenter for today. Dr. Ashley Hughes is an associate professor in the School of Medicine at Case Western Reserve University, and she also is a research informaticist at the Metro Health Center for Clinical Informatics Research and Education. Dr. Hughes uses human factor approaches to conduct mixed method informatics research related to the coordination of care. Her work primarily focuses on using socio-technical systems approaches to identify and target coordination needs for individuals that are living with chronic and complex conditions and subsequent interventions to improve care quality and patient safety. And so today, Dr. Hughes will be discussing health informatics. So I will turn it over to you, Dr. Hughes.
Thank you so much, Mackenzie, and thank you everyone for being here with us today to learn more about health informatics. As this is a really broad topic, unlike some of the science cafes that have been done previously, I have a few poll questions that I would like to ask you, mainly so we can tailor some of the discussion points for today. So if you can go ahead and launch the poll, Laura and/or Mackenzie. If you could let me know, I mean, this is very broad and but this will help us focus our discussion a bit more today on things that will be relevant and hopefully of interest to you. Okay, we've got some responses coming in. Okay, I think we've got we can give it maybe another minute, but soon we'll be ready to move to the next question.
Yeah, I see there's only a few people, so I'll end this in about 30 seconds. There's only two
Great.
people who have not responded, so.
Okay, great.
Okay, I will go ahead and end the poll, and
Mhm.
you should be able to see the results.
Okay. So it looks like most people are joining us with some type of public health medicine or nursing background. We've got a mix of people from different levels of education, different types of roles that they play um, on grants and in the research process. And Mackenzie, do you know how I can access what people may have put in for question number 4?
I am seeing that too, that I can only see the percentage that answered. So
Okay.
let me try to pull that and then I will put them into the chat.
Okay, great. Yeah, this is excellent though. Thank you everyone for sharing your background and experiences. And were they able to see as well, or loads of data? Yeah, data. Mackenzie, were they able to see the poll results as well?
Oh, yes.
Okay,
Yep. And
fantastic.
I see Laura, yes, is starting to put all of those responses into the chat.
Great. Fantastic. Okay. And so do I need to share my screen again to,
Oh no, we can still see it, so you should be able to advance your slides.
Okay, fantastic. So today's talk, since we're talking about something really broad, which is an entire field of health informatics and some of its different applications, it really makes more sense to have a grounded topic to really see these approaches and concepts in action. So, we're going to talk about an overview of what health informatics is. I'm going to share kind of what my flavor or my approach to health informatics is, given my educational background and interest that Mackenzie shared with you a little bit earlier. And the example that I want to share with you today is on some of the work that I've done in infection prevention and control. And it's really just to give you a case of the types of things that you can do with health informatics that may not really meet what you think of when you think of a health informatics approach, that we can do mixed method data, that we can use qualitative data, that we can, in addition to some of these things that may come to mind for you in terms of electronic medical record, collected data, or algorithms, or complex technologies. So, as the agenda, right, I've mentioned this somewhat already. We will end with talking more about how to leverage health informatics within your own research and or practice, because this is the world that we live in today, that you just really can't go to a doctor's appointment anymore without, or if you're practicing, someone practicing in medicine, nursing, or as an MD, there's no escaping the realities of the electronic medical record. So we'll talk about opportunities to incorporate this within your work. So there are ongoing conversations at the national level. This is an example from VA of what clinical informatics means, but every professional society and each country actually has had their own definition of what health informatics is and what health informatics is not. The commonalities that I have seen is that it includes some sort of interaction with health, aspects related to clinical care, as well as information and communications technology. So, as many of you noted, there's data, there's technology, and that you need some sort of, this is all kind of applied to health. The American Medical Informatics Association, if you're interested in health informatics, they offer great resources in addition to our local CTSC. On what really health informaticians do and how to get in contact with one. But also, we'll talk more about that toward the end of today's talk of, plugging into the health informatics work and the amazing resources that are at your disposal through CTSC and other mechanisms in the Cleveland area. But, they also cover things like data governance, management, and analytics. There's also a level of professionalism that I think there are a few models now that have expanded the definition of health informatics to be more of a multilinguistic conductor, which, so you are looking at people who have familiarity with the data to the point they can speak with a programmer and also better understand your needs or your client's needs or your grant funder needs in terms of what what types of data may be required, what the strengths and limitations for using that approach may be, um, and really sort of serve to help the communication processes between all of these different fields that come together oftentimes to make a grant or project possible, including implementation of a new technology. Um, as I mentioned, the adoption of electronic health record is ubiquitous, and with the HITECH Act that came out with the Affordable Care Act in 2010, the field has exploded. Where we went, not that terribly long ago, 15 years ago, this was not as prevalent as it is today. The more recent definition and model I like to use for defining informatics really showcases how interdisciplinary the field is. And so Valenta and colleagues in 2018, as part of an AMIA whiteboard paper, defined these foundational domains of health informatics, where it shows really at the heart and core of what we're doing in health informatics is that we are taking approaches from a broad understanding of health, social and behavioral sciences, as well as technology to really take these aspects and apply them to the science and to apply them to health and the way that healthcare is delivered. So we have foundational domains here that cover aspects of leadership, of being able to voice opinions and be able to lead conversations related to health and data, professionalism, and that we're able to navigate alongside healthcare workers and meet levels of professionalism that may not necessarily be inherent in our own field or domain. And that really also, this all requires having some core domains of interprofessional practice. And the way that this is structured is that all of these core domains sort of scaffold and build, if you're able to imagine it more as a 3D model, so that it's really taking from all of these different aspects, domains, and fields in order to really look at that multidisciplinary, even transdisciplinary approach to understanding our data, the technology and action, and so that we can, identify areas for improvement and assess current states. My particular approach and my particular background and training have me well positioned to look at these particular domains in human factors and socio-technical systems within the health informatics frameworks. So I know this is a lot of jargon, so we're going to unpack it a bit. So, what is human factors? So, human factors is also an interdisciplinary field that spans engineering as well as computer science and psychology or social science methods to better understand humans within their context, particularly when they're interacting within a complex system or with a complex system similar to navigating a complex organizational setting or an organizational setting that includes use of technology, which is what we call a socio-technical system, and that you have social aspects of the work environment as well as your technical aspects or your technology and data aspects. So this definition of human factors engineering comes from the International Ergonomics Association. My particular flavor, so I was trained at the University of Central Florida in human factors. I always worked within healthcare and had the fortunate, I was fortunate to find an advisor who, despite being in social sciences, had several healthcare projects. And post graduation, I did some additional training I was split between the clinical informatics core and the health services research core at the Center for Innovations in Quality, Effectiveness, and Safety with Baylor College of Medicine and the Michael E. DeBakey VA Medical Center. Um, it was there that I really began having more of the foundations for looking at clinical service delivery and health services research and perspectives within them and look at those intersections to really try to better understand care coordination and how it appears in many different forms, including through the technology and different data that we have at our disposal. And I launched my independent research career at the University of Illinois Chicago in biomedical and health information sciences. I continued with the VA up until more recently, where I joined Metro Health in the Center for Clinical Informatics Research and Education in the Population Health Research Institute. So when we think about human factors or these socio-technical systems approaches and health information technologies, anyone who has witnessed even just going to a doctor's appointment, you know that the nature of work and the way that medicine is now delivered, that the nature of work is complex, and that oftentimes there are multiple types of systems in which our care providers have to interact in order to retrieve information, record information, and then transmit that information for whatever may be needed, whether it's a basic prescription as part of a primary care visit, or if it's something more complex, like what we'll get into with infection prevention in terms of, trying to treat or reduce the spread of a multi-drug resistant organism. But we can think of this as really targeting, trying to understand the human in their what is being asked of the human as they're interacting in this complex care environment in this organization and the technology and the data so that we can try to meet the human's needs, also known as the novel idea that doctors are humans too, and care providers are humans too, that we meet their needs in order to improve overall efficiency, reduce any sort of safety threats that may be due to working around the systems, the HIPAA compliance systems that are in place, and with the end goal, of course, of enhancing patient safety and care quality. I really appreciate Dilbert for a number of reasons, but particularly with this comment of, I need to access company data from my iPad. Dilbert here is trying to be more efficient. And of course, administration said, if I help you, every employee in the company will want the same thing. They'll want to do their jobs more efficiently. I can't encourage that sort of thing. So, really, when we're talking about complex sociotechnical systems, it's not always just about the technology, but really the context in which the technology is being used and deployed to better understand and address any sources of inefficiency, including potentially unhelpful supervisors. So we're talking really broad here in terms of what health informatics is, what it may not entail, really looking at this from a broad perspective. Now I want to ground this within what it sounds like. I'm assuming maybe some of the nurses here may have some background in infection prevention and control. If you do have a background in infection prevention and control or practicing, would you mind raising your hands? I would love to see how much I probably don't need to break this on too much, but I would just love to see who's here from infection prevention and control. Or we're joining Zoom from our lunch break. Um, and that's okay too. Um, so as I'm about to move into some things that are have received funding from the federal government, I have a few disclaimers before we really get started in this case example of this prior work. So this work comes as part of this was supported by a query grant, which if you're unfamiliar with VA speak, this means that it was a large grant that was focused on implementation. So it's really more of not technically designated as research, but more so implementation of best practices to work with our operational partners on an applied problem. Um, I do not represent the VA or nor do I represent the US government. And if you have, I do have some citations incorporated within this presentation. If you have, greater interest in exploring those publications, I'm happy to share them, or you can request a copy of the slides as well. But we did receive this as part of a very large team, and what I'm sharing with you now is a very small subset. Our overarching project was to deploy something known as and support the deployment of something known as VA Bug Alert. So if you're unfamiliar at all with the VA system, they have been on a large integrated electronic health record system. This was deployed the initial version was deployed when everyone was on the computerized physician reporting system, also known as CPRS. Um, and we partnered with they basically revamped the VA Bug Alert tool, also known as VEBA, um, so this was in partnership with the National Infectious Disease Service as well as the Multi-Drug Resistant Organism Program Office, really as a health informatics tool to help support infection prevention, people working in infection prevention at each site federally, with detecting and responding to multi-drug resistant organisms before they spread. Now, alerts, they would basically receive alerts. Some of these would be they could customize their alert settings within this feature. Um, and this was developed, again, by people who are familiar with infectious disease work, but are not necessarily end users. So as part of our project, this tool was and is freely available to anyone within the VA working in infection prevention. They just have to request access to the tool itself, and it's available at the site level. So um, Again, these alerts are customizable. They can send emails and reports of how many multi and types of multi-drug resistant organisms that are present within a given facility. Also of note, one of their improvements was that if a veteran has a history or had a history of having an MDRO at one point within the last 10 years, it would show up upon admission without necessarily having to do additional work like a swab, which is often needed for MRSA, or doing additional, it would basically designed to help infection preventionists triage their work. And if someone was recently diagnosed or um, was recently discovered to have an MDRO, the infection preventionist would be notified if that person was being transferred from another VA. So interfacility transfers would also give alerts or notifications. Again, all of this being sort of customizable within a dashboard intended to provide some decision support as well as active surveillance for infection preventionists. As I mentioned, it's kind of went through a period of a makeover where the MDR program office enhanced VA bug alerts features to be able to detect vancomycin resistant enterococci, VRE, Candida auris, carbapenem resistant bugs, as well as I already mentioned MRSA. So they were beginning to kind of expand their list. And as part of this project, really what we were looking at is that not many people were signing up for VEBA and not many people were actually active users of VEBA. And we, as part of again, a larger initiative to enhance its implementation, we conducted rapid style human centered design interviews to essentially find out what this looked like within an infection preventionist workflow. Um, the original interviews were really sort of targeting, it was across two phases. Again, there are publications, it's a little more of a complicated, um, we basically ended up randomizing some of our enhanced implementation approaches, and it included other things, including audit and feedback strategies. Again, those are not fully relevant to what I wanted to share with you today. But we had two phases where we were doing these rapid style human-centered design interviews with infection preventionists, some of whom were not quite registered for VEBA or VA Bug Alert, and others that were registered but not actively using VA Bug Alert. And so as part of these human-centered, this goes into some of our approach for actually gathering, identifying our sample. And again, there's more published on this. And we did try to account for things like geographic region, just knowing that that can play a big role in types of antibiotics available, used, and types of infections that can occur. We ended up across both phases. So what I'm actually going to be presenting is across both phases of increasing registration as well as utilization. In that overall, there were 23 sites that we could include as part of our interview guide or include as part of our interview study. And so we structured a semi-structured interview guide to prompt infection preventionists to describe their current processes for identifying and responding to a multi-drug resistant organism. And that was common across both phases of our interview approach. And I wanted to share this especially to show that health informatics, right? Especially if and when we're trying to better determine how to make a technology more acceptable to the end user to promote uptake and use, that oftentimes qualitative is also necessary to better understand workflow. Um, we had three trained coders. I was among them and helped lead this effort where we double coded all transcripts according to a human factors socio-technical systems framework. So I want to share with you some specifics about this framework as it is fairly prevalent in the field and it informs a lot of the work that we do with health informatics implementation studies. So this is known as the Systems Engineering Initiative for Patient Safety. Um, if you are familiar at all with care quality models, we often look at inputs, processes, and outcomes with sort of an adaptation or feedback loop. So you'll notice that the structure may be similar to what what you're used to seeing for understanding care quality and safety in healthcare settings. This is very broad. It is not implementation specific, but rather trying to understand the user, in this case, the person or persons within the broader work system. And what is relatively unique to the SEEPS model is that we know that the person's ability to provide their professional work, being able to, in this case, detect and respond to a multi-drug resistant organism, is going to be influenced by their interactions with the tools and technologies that are available to them, their ability and proficiency to use those to the best of their abilities, their organization setup, their staffing, whether it's sufficient or insufficient, any local policies that may be enforced, could also influence the way that they conduct work. There are also different tasks that people are asked to do. Now we're focusing predominantly here on multi-drug resistant organisms, but sometimes people would share their competing priorities in relation to detecting hospital-acquired infections and other types of phenomenon that fell within their job as an infection preventionist. So all of these are allowed to interact. We used a predominantly deductive coding scheme. So if you're not familiar with qualitative research speak, it means that we based our codes fairly explicitly on the SEEPS model, also allowing for double coding to capture where those interactions occurred. Once we did that, we everything was double coded. We came to consensus. We reviewed our interactions because what we found that was really interesting about this project is that there were really dense areas where a lot of codes were appearing all together, really highlighting the fact that infection preventionist work is somewhat complex and that they're having to do this using multiple tools at their disposal, including navigating things within their work environment. So this was really honestly in the last 10 years that I've done this, this was kind of really the first time I've seen things clustered this way. So another reason to share this work. But we know that, right, ideally these things interact. They influence the way that work is done, collaborative work, patient-facing work, as well as professional work, and that those processes influence the types of outcomes that we see. In this case, does an MDRO spread? Are enhanced barrier precautions put in place? What is happening once those things are detected or once there's a response in place? So themes on VEBA use are overall findings related to the workflow. So this has been a very, again, a complicated piece to unpack here in that the first finding was basically IPCs are using lots of different tools and technologies. And as one person shared with us, there is no one source of truth. Also, I should share that we ended up getting about 19 sites, so a fairly decent participation rate. So as this one person said, was kind of elaborating on why they were using multiple technologies, each technology they have has its own downsides. So sometimes they mentioned the downside of doing manual tracking, of having to print out lab reports to make sure that they're not missing the presence of a multi-drug resistant organism or superbug at their facility. This particular person just mentions trying to track ESBLs and sometimes the process that they would use or the technology they would use would differ based on the type of organism that they're trying to track, which honestly, even reading the transcript sounds somewhat exhausting. I'm not sure if they're part of my bug alert, if they plan to be in the future, but right now we're not seeing it at this time. So they're showing that they have to do things manually, and that sometimes there seems to be they have to do things manually in addition to using technologies. So as there's sort of no one source of truth, we also kind of, as a sort of sub theme of this, we found that really um, they cobble together their own um, systems of redundancy. And systems of redundancy is more of an engineering term that essentially you're trying to create high reliability, and they are trying to compensate for the fact that none of these tools are completely perfect. So they will essentially make their own process, their own system for creating checks and balances of, some even refer to doing coding and training themselves in SQL just to make sure that their lab didn't make an error or that the reports are reading correctly. But they essentially cobble together these things of, okay, well, I'm going to check Theradoc because that's very time sensitive. I'm going to check Vista because this is going to help me. It looks like at one point Theradoc didn't catch what this GUI mail did. So I use both of them to make sure nothing falls through the cracks. So it seems like a lot of effort goes into just trying to, including manual checks and deep coding that's not part of an infection preventionist job description, goes into trying to use systems to do their job. Um, the second theme that we found is that while we assume a lot of the literature on this is that we assume that MDRO responses um, and detection are sort of part of the same thing. Obviously, when you find a superbug at your facility, you want to notify somebody or take proper precautions so that that bug does not spread to other patients. Um, However, we sort of saw them as two different tasks that an IPC must do. And so passing the baton is tricky business. So once they get that information, right, sometimes there were only one or two infection preventionists at a given facility. And that's why we recruited based on facility, is that that information then had to go to someone else to actually take action. And the process of conveying and ensuring receipt of that information was complicated. They were trying to notify nurses on the front staff. So trying to make sure that that's communicated, that that's not just a note in the EMR that may get missed. Sometimes they ended up having to make phone calls, mentioned it during rounding. Sometimes they worked with frontline nurses just to get a system in place so that they could have peace of mind that a patient's barrier precautions were put in place and that the message was received effectively. But there really was no, um, just as there was no one source of truth, there really was no standardized approach for passing the baton in this case. Um, Given that VA Bug Alert also intended to look at and promote interfacility transfers, we saw that sometimes passing the baton also meant passing information from one health system to another. So when a facility was located, there were two VA facilities located near each other. VA Bug Alert was seen as pretty helpful as they might get interfacility transfers from them. And in those cases, they could say, oh, we were able to detect, we knew about CRE. They knew about the superbug upon admission. And so they were able to look at these flags um, and respond more effectively. However, conversely, when there was not a nearby VA facility or most of their transfers were coming from outside of the VA health system, then it was a very different process and a very different approach where they did have to manually do those swabs and ensure that compliance was in place for detecting and doing testing for MDROs. So I give that as an example of how health informatics research may look different depending on your goals and depending on the background and training of the person that you're partnering with in order to do health informatics work as part of your research or your practice. So, health informatics can give us really broad insight or really specific insight, depending on how you want to go about your data collection, whether you're looking at large data sets like we talk about with the CTSC in Cosmos or Trinetics, or if we are really trying to get a better sense of people's workflow, that can give us insight into what that data means. Um, you can also leverage some of this information to help position, tailor, or create interventions that improve user interaction with technology. So, in the example that I provided, these semi-structured interviews and rapid qualitative analysis, were the results were shared pretty immediately, as soon as we had them with the MDRO program office and the VA, who could then make changes to the technology. And or otherwise we could convey back why a change couldn't be in place. One that was really commonly requested was for C. diff, which is not technically a superbug, but a common infection people wanted to detect and make sure that treatment was in place. However, we were able to at least convey back that there were just so many different ways of diagnosing C. diff, that it was difficult to, at least I believe this was the case, and the type of C. diff, that it was difficult to identify the programming logic based on the EHR data that would go into making that alert more meaningful. So even if you don't get the exact answer you were looking for in pairing qualitative and quantitative approaches in health informatics, you will at least get insight into why a certain programming feature should not be programmed into your tool. This is an exciting time to be in health informatics, not necessarily because of the funding opportunities themselves, but really, I think because of the flexibility of the approaches, and some commitment that exists. So, on a federal and local level for health informatics work. So it really depends on how you're trying to use health informatics, what approach, education, training you're coming from in using health informatics, and of course, the type of health informatics methods that you're trying to engage. So if and when um, what can be tricky is if and when the most novel, where if the contribution itself is disease agnostic in health informatics work and more of a pure method enhancement, um, these are more disease agnostic types of funding that you would pursue. So National Library of Medicine still has, I don't think that their focus is on health disparities anymore, but it can vary in terms of now the accepted terminology that NIH will let you use or prefer that you use. Historically, the Agency for Healthcare Research and Quality has been a useful partner in their digital healthcare research grant application process. And ARPA-H is another very large funding opportunity that can be beneficial in this case. From time to time, because National Science Foundation will support, has been a strong advocate also for health informatics methods and approaches, again, when the contribution of science is to the method, rather than the more so to the advancement of health. Um, I don't necessarily write for NSF explicitly, so I more so have things tailored on the health side. So NSF and NIH have, even though the deadline has passed for this particular call and announcement, but they have historically about what I've seen about once a year, they offer a joint application looking at some sort of specific component of health informatics that they're looking to fund, right? Where that does exist at the unique intersection between data technology and health. Um, the last call was focused on artificial intelligence as well as advanced data sciences. And again, the methods being more of the focus for the piece of innovation. Unfortunately, right, I mentioned the NSF and NIH joint funded opportunity. That opportunity has now passed. That was due back in October. ARPA, I believe, still technically exists, but in today's current funding funding atmosphere. I definitely, unfortunately, cannot recommend any applications going into ARC, as I'm sure you are aware, and ARPA H is not is questionable in the future as well. National Library of Medicine does have some downsides to its applications, especially DP1 and DP2. Only that they are highly, highly competitive and that they are kind of they're expected to be incredibly risk-taking, and they are for the director of NIH is what that mechanism is for. There are, from time to time, even though we know that notices of special interest through NIH are no longer or are not going to be a thing that will be coming down the pipeline, we should not be expecting to see any more NOCs. However, National Cancer Institute still has a professed interest in informatics technology for cancer research. There are times that you'll want to read, obviously, your calls very explicitly. I have found some success within the implementation and dissemination uh, cores or funding opportunities when they engage informatics. And so just obviously you can apply and use health informatics within any type of healthcare innovation or toward any type of health or disease specific issue. What I do recommend, even though obviously we're not going to go through and discuss all of the current divisions of NIH or how it may be restructured in the near future, but please note that there is a study section that you will want to take note of, known as the Clinical Informatics and Digital Health study section. They have been a standing study section for some time. I review for them on occasion, so they do span the gamut in terms of having, if you are more interested in developing a new large language model for your AI or innovations to a more, heavily data science oriented project. You would want it to be reviewed within the study section, but also if you are hoping to improve people's use of FHIR standards, which are to help improve interoperability or communication between records, and people's use of those things that exist, more in the human factors and socio-technical system side of things. That also would be an appropriate study section for you to note for anything that's really along all the dimensions of health informatics. So I have just a few conclusions here before we get to questions and hopefully some takeaway points for you. And that we know that health informatics, as it's currently defined, is very broad and spans multiple disciplines, but that it essentially takes technology, people, and healthcare. And when you are seeking collaborators within this space, it's really important that you specify really the type. What is the ask? Are you in need of someone who's going to be able to merge multiple data sets? Are you going to need manipulation and digging into the record? Are you going to need more of a data science component or more of a programming, building an actual tool? Versus are you going to need someone who is able to evaluate a tool's current use or utility? All of these still technically fall within health informatics, and the more that you can specify and convey what you need for your project, the more that the CTSC and others will be able to help you. And that includes Cosmos as well. If you are a Cosmos user or a big data set user, there are multiple, even within the realm of data science or even big data There are people with different access levels and different proficiency levels, and Cosmos has further distinguished the types of users and trainings that they do that all could affect, right, the ability to actually conduct your project. Hopefully, you also are already aware that you can request clinical informatics consults, whether you're doing data or you want to, or you have a like a Trinetics request for getting a data set, or you have need help with looking over a Cosmos query, that you can submit a Spark request for that, or to help you find a collaborator on your next project or proposal that's going in. So the specific example, going back to that, the example that I provided with an infection prevention and control shows that really you can use qualitative methods are also part of health informatics or can be um, if you're really trying to make sure that something is usable or you're thinking of an implementation project. This can be a really core piece of making sure that what you have in mind for implementing or what you're trying to design is going to meet the end user's needs. Funding opportunities are obviously changing at the national level along with federal priorities, but it does seem that NIH, along with other federal agencies, have a commitment at least to artificial intelligence and training in data sciences. So um, while I don't like having a large cancel box on the different funding opportunities I shared, it does seem that we will that applications will be that incorporate health informatics work and approaches will be reviewed will be at least seen positively from a federal priority standpoint. So here, we've got about 10 minutes. Thank you for listening, for more questions. And I want to hear kind of how do you envision using health informatics in your work? And of course, what questions do you have for me, based on what we've shared today?
All right. Well, thank you so much, Dr. Hughes. I'm just taking a look at the chat so you can put your questions there or feel free to unmute yourself if you have a question or a comment. So while people are typing and thinking of their questions, this is more of a broad question. So, where would you suggest to start as someone like if they were a trainee or someone who's more established but just hasn't really been in this space before, but like would like to start?
Sure, I would say it doesn't differ much from getting involved in any research application or type of training, is that you would really identify a mentor and specify what you think you might be interested in and get involved in an ongoing research project. I think that would be probably the best way. Or, if there are courses and things available as well. But, that's really where I would, if you are completely unsure of where to start, um, then probably listening to some of the lectures through CTSE, and but getting a mentor, working with them, um, doing possibly doing an independent project can give you a really good sense of whether that's an area of informatics that you would be interested in pursuing.
I put this in the trash, but I just wanted to remind everyone that there are informatics open office hours the first Wednesday of each month that the CTSC provides, and Dr. Hughes and Dr. Jarrett from University Hospitals help coordinate and run those. There will be no January session, but it will resume in February. So that first Wednesday in February of 2026.
Thank you, Laura. Dr. Ghosh?
Oh, you can just call me Rini. Um, I have a follow-up question from the last one, actually. Thank you for answering like where a university student or somebody would sort of start from. How about from a workforce development perspective, how about high school students? Like, I feel like there's a big gap between what happens in primary school and secondary school before kids like go off to college. They hear about all of this stuff that's out there, the AI and the data infrastructure and the bioinformatics. And, they have questions about how to get started and what they would do at that part of the, like, in high school to get prepared for their undergraduate careers. What kind of advice would you give them?
Um, that's an excellent, excellent question. My advice is I tend to tailor things based on where people come from. So it is difficult to give a blank statement to this. It does seem that demand for data science and proficiency in artificial intelligence are really kind of the more of the technical aspects of health informatics appear to be in high demand. And I'm only basing that off of what we see right now and what we can see in the near future, all of this being subject to change. But I would encourage them to really explore those areas. And part of the reason, so health informatics training is not really available at the undergraduate level. It requires certificates or a more advanced degree, which is also why I found it almost alarming that infection preventionists are having
Yeah.
to really kind of become health informaticians themselves. But kind of, familiarizing themselves with um, SQL coding, basics of machine learning and artificial intelligence, and using that as a starting point because these things are changing so rapidly.
Right.
Yeah,
Well, thank you.
yeah, thank you for that. I see there's a question in the chat. What are the key challenges and opportunities presented by the rise of AI applications? And AI applications in this case is talking about, I'm assuming this, and please correct me if I'm wrong, but I'm assuming that AI applications are simply like within the health record or like health services, or I mean, there's so many different AI applications, right? Um, so I'm just assuming like at point of care. And I would say that some of the challenges have to do with, again, the technical aspects of artificial intelligence are, and its capabilities are changing daily. To the point that, there are people who have contacted me saying, hey, we designed this thing, we got your input, you helped facilitate design of what would go into an AI tool, but they keep wanting to update the language model behind it, and we keep getting different output depending on the language model being used. Is newer always better? And I would say that newer is not always better. And we are having to, there are a few tools that help with identifying and quantifying even how good an AI is at doing a particular job. And you do have to drill down sometimes into that socio-technical system, right? Like what's the use, what's the purpose, and sort of craft some metrics around that. But there are things that we can measure, like hallucinations, how much of what is coming out of the AI is simply fabricated, and not really based on much of reality. I think those are some challenges just in terms of how quickly this is advancing. And there are very obvious opportunities for testing AI and its potential. I think that we need to be examining the question that economists, that people in economics are asking every day of, is AI worth it? Is the juice worth the squeeze? And I don't know that we have an answer to that, especially with the variety of applications that AI brings us. Thank you for that question. there any other thoughts or questions? Was there anything that was, we could talk about AI for some time. I'm happy to talk more about AI.
Okay, well, as people are thinking of any last minute questions, I will just share a final slide. It's, okay. So I just wanted to share these two QR codes. So the one on the left is how to register for next month, as well as all of the upcoming Science Cafe sessions. Next month will be on environmental health on January 15th. And the QR code on the right is a way for you to sign up to become a member of the CTSC if you have not already, to stay up to date with all of our upcoming events. Okay, and I'm not seeing anything else in the chat. It doesn't look like anyone has unmuted. Okay. Well, thank you all so much for attending, and thank you, Dr. Hughes, for a great session.
Thank you.
All right. Have a good day, everyone.